गुड इवनिंग पंकज भाई।
सॉरी, मेरा ऑडियो ऑफ था। गुड इवनिंग।
Good evening, sir. Pankaj sir, Gaurang
Good
sir.
evening.
Hey,
Yeah,
good
yeah.
evening.
गीते सर का कुछ कांटेक्ट नहीं है।
आपने फोन की कोशिश की क्या?
दो टाइम फोन किया, ही इज नॉट पिकिंग अप।
ओह, मैं एक मैसेज कर देता हूँ।
हाँ, yes, sir.
गौरंग भाई,
Yeah, bolo. Shall we start?
Yeah. Dr. Gite is traveling to Nasik, so he may not be able to actively join. He will join whenever he is in connection.
Okay, okay.
Hmm.
Fine. Then I think we should start the cases.
Sure.
Who is answering this to
Dr. Anuj and Dr. Ekansh.
Good evening,
Anuj and Rahul.
sir.
Dr. Anuj and Dr. Ekansh.
Yes.
Ekansh is not there, or is he there?
both of them are there? Please identify.
Sir Anuj from Puttaparthi, sir.
Wow. Okay.
Sir, he is
And
just
who else is?
online.
And the second student?
Yes, he is just getting online, sir. I just called him. He's just logging in.
Okay. I think many of them have gone to Nadiad also, and I'm sure that experience must be excellent in Nadiad. So if you have got any tips or anything, if you want any change in our case presentation or any teaching, okay, you can give the suggestion. Okay, fine. I think we should start now. He will join, na? Anuj?
Yes, sir.
The other student will join. So meanwhile, you can,
Yes, sir. Yes, sir.
okay?
Yes, sir.
Yeah.
So, sir, 28-year male patient is presented with complaint of pain over the right flank since 2 months, and burning micturition increased frequency since 1 month. Pain over the left flank since 1 month. So, sir, 28-year male with flank pain. So, I would like to know about the more detailed history about the flank pain, sir. Whether it is colicky pain or it is dull aching pain.
Yeah, go ahead.
Yes, sir. And then whether it is radiating or migrating pain, whether these aggravating and relieving factors for the pain, whether it is associated with fever, nausea, or vomiting, sir.
Yeah. So this is the history. Come on, you can read it. And if you anything
Yes.
is missing, you can add whatever.
Yes, sir. Pain was colicky in nature, sudden in onset, radiating from loin to groin, gradually progressing and has increased since last 1 month. Associated with nausea and vomiting, no specific aggravating factors, relieved on taking analgesics. Pain on left flank was similar in nature, radiating to back and relieved on taking analgesic.
Bridges change.
So there was no history of lithuria, hematuria, fever, chills, rigors, or no history of instrumentation or catheterization. Uh, no history of facial puffiness, exertional breathlessness, or lower limb edema. No history of jaundice, headache, or backache. No history of bleeding disorder or anticoagulant therapy or blood transfusion, sir. No history of hypertension, diabetes, tuberculosis, or hypo or hyperthyroidism. No allergies. Family history not significant. Personal history: patient mixed diet, appetite normal, normal bladder and bowel habits, and sleep normal. No any addiction, sir. In past history, sir, I would like to know about any history of any intervention for stone disease.
Yeah. So they said that there is no history of any instrumentation.
Okay, okay, sir.
Yeah.
In
So
general,
examination. Finish your examination.
sir, in general examination, patient is conscious,
Is
cooperative,
normal. आगे बढ़िए.
normal. Yes, sir.
So instead of really reading every line, just go
Hmm.
through it and give your final impression.
Yeah.
Yes, sir. On inspection, abdominal inspection is unremarkable, sir. No positive findings, sir, in on inspection.
Except mild right renal tenderness or fullness, not tenderness. Okay, fair.
On palpation, sir, no obvious lump was present in the on the abdomen, no tenderness. Percussion, renal angle dullness, otherwise auscultation was normal, sir. Rest of the examination is unremarkable, sir.
Even the per rectal was normal.
Yes.
Right. Fine. So now this is your examination. Now tell us, okay, what is your differential diagnosis after this, clinical examination, and what you will like to do?
Sir, as a 28 years male patient, he was presented with complaint of flank pain and burning micturition and increased frequency. My most probable diagnosis will be first differential diagnosis will be stone disease, sir. And
Okay.
yes, sir. Then any cystic diseases or any infective etiology will be in the differential diagnosis.
My suggestion will be instead of saying stone disease, you see, stone disease is very broad. So here we have flank pain and burning and increased frequency. So upper tract as well as lower tract symptoms. How will cyst disease cause flank pain and lower tract symptoms?
Sir,
So instead of saying urolithiasis, I would prefer if you say that I'm suspecting lower ureteric stone. Aren't we thinking of lower ureteric stone at this time?
yes, sir.
Urolithiasis would become extremely broad, and we need to, based on history, focus somewhere.
Okay, sir.
So what Dr. Maheshwari is asking you is that you tell us that what are the, you know, urolithiasis cases where you'll get the upper tract as well as the lower tract symptoms.
Yes, sir. Sir, stones in the kidney or upper ureter will present with flank pain, and this lower ureteric stone or bladder stone or maybe urethral calculus may be present with associated LUTS symptoms like increased frequency and burning micturition, sir.
But urethral stone will not present with flank pain.
Uh, Yes, sir.
So basically, then we are just left with lower ureteric stones, at best vesical calculi, which have just slipped down. But otherwise, I don't think at this time, with bilateral flank pain, dysuria, and increased frequency, my most probable diagnosis is ureteric calculi, lower ureteric most likely.
Yes, sir.
Why?
गौरव भाई और कुछ कहना चाहते हैं?
No, it means I think that what you are perfect, that it is a lower ureteric stone, and sometime it may be associated, means it may be a ureteric calculus along with the vesical calculus. But
Yeah.
these are the two things I think you should say.
So
Yes.
now, how do you want to proceed further?
So I would like to proceed with routine investigations, including blood investigation, complete blood count, renal function test, and urine analysis, sir.
बताइए.
Yeah, so what are your findings? Say.
So urine sir, proteins are present, sir, and
Hmm.
pH is 5.5. Blood present on chemical examination, and the WBC is 20 to 25 WBCs are present, sir. So I would like to do urine culture first, sir.
Hold on, Anuj. Again, my suggestion here, you see, we are just preparing for exam. So my suggestion will be don't talk of things where you don't want the discussion to go. The moment you have discussed proteins, then let's start discussing proteinuria now. Okay.
Yes.
So how I will read this urine routine? I would say that this is a urine routine showing hematopyuria. Full stop. हम
Okay.
ओपीडी में भी यही देखते हैं ना, हम कहाँ देखते हैं कि 1+ प्रोटीन है या 1+ क्या है, ठीक है. Anything extra you say, you are inviting the examiner to go in that direction. So my opinion about this will be this patient has mild hematopyuria. Now ask me, decide the next investigation.
So yes, sir. Urine culture, sir.
Yeah. So looking at this, you ask for urine culture. So why you ask for urine culture?
Sir, as patient is having symptoms of lower urinary tract, sir, burning, micturition, and increased frequency.
No. So
And
you have asked for to treat the patient, huh?
yes, sir.
So now, yeah. So now, which drug you will like to use?
So, sir, first I would like to do the ultrasound KUB of the patient, sir.
Okay. Show him all those investigation which he has asked. Bridget. Fine. Anything obviously?
Sir, blood reports are within normal limits, sir. No.
Okay. So
Yes.
now you want
Again,
ultrasonography.
I would again give you one suggestion how you should be reading this. I would say hemoglobin is normal, total count is not elevated. You see, I'm also deciding how I will be treating. If total count is elevated, I'm suspecting infection. So total count is not even increased. Creatinine is normal. Basic blood parameters look good. Calcium was borderline high, but PTH is normal. Okay,
Okay, sir.
move ahead. Now, what next do you want?
Sir, ultrasound KUB, sir.
Only QE. Okay. We don't have film.
No, sir, it was not there. It was outside
Okay.
patient.
Sir, ultrasound shows liver, gallbladder, spleen, and pancreas normal, sir. Right kidney normal in size, shape, and ecotexture. A 4.5 mm calculus in the lower pole calyx. Right ureter, moderate hydronephrosis and hydroureter noted. Uh, up to a 20 mm calculus in upper ureter, sir. Approximately 4 centimeter away from PUJ. And left kidney normal size, shape, and ecotexture. No evidence of any focal lesion. Multiple 7 to 8 calculi noted. Largest 15 mm at renal pelvis. Left ureter mild hydronephrosis and hydroureter noted up to a 7 mm calculus in lower ureter, approximately 1 centimeter away from VUJ. And urinary bladder distended. No evidence of calculus or mucosal irregularity. Prostate normal.
No, my friend, again, don't read the full report. Give the inference. You read it in your mind and give a final answer to it. So I would here say patient has bilateral multiple renal calculi with bilateral ureteric calculi, right upper ureteric large stone with moderate hydronephrosis, left small low aortic stone with mild hydronephrosis. Who is interested in listening about liver, spleen, and bladder and XYZ?
Yes, sir.
पर देखिए आपके रीडिंग स्पीड से ज्यादा हमारी पढ़ने की स्पीड है. So you only read it fast and give the final inference.
So, sir,
So
bilateral
yeah,
ureteric calculi with left-sided renal calculus, sir.
Bilateral renal calculi.
Yes, sir.
okay. So on the left hand side, there are saying bilateral, multiple. So what will be your inference when something like this is there? What comes in your mind? You think there are multiple small stones, or it may be something else?
Sir, on left side, it looks like multiple calculi. So it can be the secondary calculi, sir. Secondary to
Okay, so
PUJ.
one is a secondary, and second thing is it can be a Staghorn calculus because the ultrasonography cannot detect the actual shape. So many a times it says that there are multiple calculi, but there may be a Staghorn calculus.
Yes.
Anuj,
Okay,
you
fine.
said
So
secondary to PU junction obstruction. What did you say?
he says
Secondary to what?
secondary to PU junction calculus. There is one stone, it is said 1.5
Yes, sir.
centimeter, 15 millimeter at renal pelvis.
Yes, sir.
Okay.
Yes.
Fine. So now next what you want?
So I
Now,
would like
what
to,
is your now how you are going to explain about the lower renal tract symptom?
sir, as the stone in the VUJ region, it can cause lower urinary tract symptoms like increased frequency, sir.
So you can say, okay, sir, it is a bilateral ureteric calculus. Then that is the reason patient has got pain in the correct flank and in the even the left renal calculus. Plus, it can also give rise to lower renal tract symptoms if it is very low down, and patient may have urinary tract infection. That is what is you are seeing in urine routine. So that is also giving rise to lower intake.
Yes, sir.
So now next what you want?
So I would like to do, sir, CT IVP in this case, sir, as patient has bilateral ureteric stones uh, with hydronephrosis, sir.
Okay. So the question is, you want to do CT KUB or you want to do CT IVP?
Sir, I would like to prefer CT IVP, sir, for because I want to know the function of both the kidneys, parenchymal thickness, calyceal anatomy to plan for my procedure also, sir.
So you are planning, you may plan PCNS.
Yes, sir.
Yeah, because earlier also we had discussed that if you are planning only RIRS mainly, then CT IVP may not be needed. In all the cases of the renal stones, we don't do CT IVP because most of the information you can also get through. But in this case, first of all, it is a bilateral renal disease. Second thing, the multiple calculi, and you might do
PCN.
invasive procedure like PCNL also in these
Yes,
cases. So you will like to know everything about the anatomy as well as the function
function. Yes,
by one investigation, correct? To
yes,
plan your management.
yes,
No, in exam they may ask you, okay, why you want to do don't want to do plain CT. So you have to both the way you have to justify whether you want to do plain CT QB or you want to do IVP. Fine.
yes.
Sure. Vijay.
This was the X-ray which patient brought from outside. We will shift to the IV.
Anyway, okay. See carefully all the films and let us know. The second student has joined, Brijesh?
No, sir, not yet. He told me that he's just joining, but he haven't yet joined. I'll just
Oh,
mess. Yeah.
Sir, this is the CT IVP films in the axial and coronal views showing. Can you go back, please? Showing right upper ureteric calculus of size around 15 mm and left side Staghorn calculus uh, with uh, with with good renal parenchyma both sides, and good contrast uptake and excretion in both the kidneys.
what about the left?
Where can you see contrast excretion? I can't see anywhere. अच्छा ये इमेज उसकी बात कर रहे हैं.
Left kidney has staghorn stones are extending into the upper, middle, and lower calyx and into the pelvis, sir.
Hmm.
Yes, sir.
In one of the film, Brijesh, there was some left ureteric calculus also, no? It is not there. Okay, fine. Yes. Yeah, tell us now what you want to do. Now this patient has come to you. You have got this many investigations. Would you like to do any further investigation? Number one. And number two, what you are going to talk to the patient and how you are going to proceed.
Yes, sir. So, sir, I will explain the patient about the presence of bilateral stones, left side staghorn stone and right side obstructed upper ureteric stone, and
Hmm.
his urine culture is positive. So I would like to start him on antibiotics at least 48 hours before the surgery, and then I will plan for left PCNL and right side URSL or RIRS, sir.
In the same session?
Sir, it depends, sir. If left side PCNL remains uneventful, no, this surgery time is not exceeding and patient hemodynamic condition is stable, then we can plan or we
So
can speed
which
up.
side do you want to start with, right or left?
Sir, as patient has both sides symptomatic, sir, good functioning kidney. It looks like left kidney is relatively better functioning kidney compared to right side, and there is a hydronephrosis on right side. So we'll plan for left side first, sir.
So which side should you treat first, a obstructed side or a non-obstructed side?
Obstructed side, sir.
So which side is obstructed?
Right side, sir.
So then you see, in these, what concept you gave me about the stones means the at the present time when we are doing minimally invasive treatment, the choice of treatment will depend on which side is obstructed, which side is infected, and which side is easier. Okay,
Yes.
left side is a reasonably complex PCNL. So I would want to finish off the right side before I move on the left side. At least I have de-obstructed the right kidney. So if you plan bilateral under single session, definitely right side first.
Okay, sir.
You agree with me? You don't agree with me?
Yes, sir. Yes, sir.
So first I would deobstruct the right kidney. If the urine in the right kidney is clear, I may proceed with RIRS at the same time. Otherwise, I would place a stent and stage the procedure at that time. And then, depending on how things go on right side, then I'll take a call about left side. Now, with the left being a staghorn, non-dilated staghorn, there is really no urgency for left side treatment. Most likely, this patient had a left lower aortic stone, which he has passed off. That is how he had lower aortic means lower tract symptoms. And now in this CT scan, we don't see a lower aortic stone.
Yes.
This is the left side is not an easy PCNL. Go to the next slide, please. Go to the next slide. Yeah. Now look at this in the first plane image. It's not an easy PCNL. Okay, so first deobstruct right, clear the right, and then plan the left side.
Okay, sir.
So Anuj, how
Yes.
you are going to in your private also when you start practicing, when you start your own practice, in such cases, exactly follow what Dr. Maheshwari sir has told you. Okay, three important things he has told. One is obstruction, second is symptomatic, and the third is infection.
Yes.
Now, you people are saying that whichever kidney is better, you will do it first. Most important thing is the obstruction. So the first you look for the obstruction, followed by better functioning kidney, and the third is infection. And accordingly, for example, suppose right side is a pyelonephrosis. Which system you will treat first?
We have to, sir, pyelonephrosis will be a emergency, sir. So we have to treat first pyelonephrosis, sir. We have to decompress the system with PCN.
So you understood?
Yes, sir.
Now, in this case, he said very rightly, there is hardly any hydronephrosis on the left side.
Yes, sir.
Correct? And the right
Yes.
side, you can see the parenchyma is good, but patient has got obstruction.
Yes.
So which side you will do first?
Right side, sir, in this case.
Right side. So in this case, obstructed. Correct?
Yes, sir.
Fine. Now both the system are obstructed. And the right side is showing very gross hydronephrosis, very thin parenchyma. Left side is hydronephrosis, good parenchyma. Which side you will operate first?
Then
Left
left
side.
side will be better functioning. So
So
we will
exactly.
prefer
So
left
you
side.
will first, yeah. So you want to first, you don't want to wait. Correct?
Yes. Yes, sir.
Okay. Now the another reason in this case, as he said very rightly, Dr. Maheshwari, what is the important thing? That right side is an easier case comparatively.
Yes.
Okay, the chances of you going wrong are very less. So what you will do, you will treat the right side, you clear the system first. If you think that everything has gone fine, you may proceed on the left side or you may stage it for the next time. First, that the right side recovers and then you want to go ahead.
See,
Yes.
Understood?
the easier side first, at least one side you have taken care of and one
Care
kidney
of.
has become safe.
Correct.
Then you have ample time to concentrate on the other kidney.
So now tell us which side you will do first in this case and why.
So, sir, in this case, right side, I will do first as the system is obstructed, sir. So, and easier comparative to the left side. So, we'll secure the one kidney first, which is easier and which is obstructed, sir. And at the same time, we can put a stent on the left side, so we can stage the procedure for left side, sir.
Okay. So you can say, okay, sir, and if everything goes very smooth, I may plan to do the left side at the same time, or depending upon the procedure, I will like to do degescenting or without degescenting, next time the stage procedure.
Yes, sir.
Can you go back to the last slide only? Don't change this slide. Now tell me, how will degestenting help on left side? Why do you want to do degestenting on left side?
Hmm.
No, sir, I mean to say stage procedure, sir.
Stage procedure means don't start left side if you feel you are unable to do it. Do you think left system will drain by a degestant? Number one. Number two, do you think left system needs drainage? If it were obstructed, you would see hydronephrosis. There is no hydronephrosis here. Two, because stones are there in multiple calyces, anywhere you place a stent, that stent is not going to drain the full system. So we have no documented infection on left side. We have no documented obstruction on left side. Then why place a stent?
You understood?
Yes, sir. Yes, sir.
Anuj,
See,
don't
every
attempt me, contradict me if you feel you are right.
No, sir, I am wrong, sir. Actually,
No, you are not wrong. You
no, no,
can
don't
defend
say
yourself.
wrong. If
There
you
is nothing
see,
wrong. Everything is right that you can defend yourself on.
yes,
So
sir.
in exam, examiners will tell you something different than what you have said. And then you need to stand your ground. You need to defend what you have said.
Yes. Yes, sir. So, sir, we can stage the procedure if we are able to complete the procedure right side within the surgical limited time and patient is stable, then we can plan the procedure on left side in the same sitting and or we can do in the next sitting, sir, PCNL for left side.
Perfect. Now tell
fine.
me, so suppose, sir, sorry, आप खत्म कर ले पहले.
हाँ, मेरे को यही था कि now what you're going to before doing this surgery, what you are going to tell the patient. Two
Sir,
important things you have to say, na? Patient is going to ask you why so many stones.
so, sir, first thing I will explain the patient about the presence of bilateral stones and need for like risk of recurrence even after complete stone clearance in the future
No,
follow.
first of all, you tell him there is a bilateral stone, he needs the treatment. So you
Yes,
will describe him about a different type of treatment, correct?
yes,
That is
sir.
number one. You will talk about PCNL. You will tell him that on the left hand side, you with a one puncture, because he might have seen many other patients undergoing PCNL one puncture in within 2 days, patient has gone home. Expenditure is very less compared to, so you have to explain him. So what are the things you will tell him about the left side?
So I will explain him, sir. Like stone, there is a left renal stone is a Staghorn stone which is extending into the multiple calyces. So it may need multiple punctures, and
Okay.
yes, sir, and it may need the stage procedure for
Number
clearance.
two. Number three.
Sir, risk of complications in the procedure like bleeding, risk of
Hmm.
pneumothorax, sir,
Hmm.
adjacent visceral organ injury, sir, on the left
So
side.
because he will require a multiple puncture, and if you see the X-ray, na, see, I don't know whether everyone will agree or not, but before doing PCNL, na, I will always like to have an X-ray. And if you see the X-ray, na, the upper calyces stones, they are going up to the 10th rib. Okay, so as you are saying very rightly, there are chances of hydrothorax, pneumothorax, or hemothorax, whatever it is.
Yes,
Okay,
yes,
so second, third thing is patient may need blood.
yes, sir.
Then you may do 2 sittings PCNL. And the last and most important thing is that if some small stone may remain behind, you will do check RIRS at the time of digestion removal.
Yes,
Or at the time of surgery, you may have multiple procedures. You may do RIRS that time also. And after everything is over, you would like to investigate this patient for stone formation
yes, sir.
so that he doesn't develop recurrence. So you like to. So all these things are very important that you are going to explain to the patient. महेश्वरी जी अभी आपका चालू करो.
नहीं सर.
Yeah.
Okay, so if suppose you, Anuj, you have all the possible facilities, what would be the best treatment for this stone on left side?
So, sir, as the stone is extending into the multiple calyces, sir, and it is extending into the pelvis, and one isolated lower pole stone is also there. So, I will proceed with, sir, simultaneous PCNL with RIRS, that is ECIRS, sir.
So this is an ideal patient for ECIRS
Yes.
because otherwise you can see that there are stones in practically every calyx.
Yes.
And the angle between the calyces is quite acute. So it will be very difficult to go from one calyx to other. And by
Yes.
doing ECRS in this patient, we'll be able to prevent at least few punctures in this patient. Now, if you decide to make a PCNL, what would be the tract size you will aim at?
So, sir, maybe if the stone burden is more, so
No,
I
no,
will.
no, you have it in front of you. What is maybe?
Yes, sir. So,
इस पेशेंट में क्या ट्रैक्ट साइज बनाओगे?
sir, standard PCNL, sir, 24 French.
So what is the factor which decides the tract size? How do you decide what tract size to make?
So, sir,
One, as you rightly said, is stone bulk. Anything else more important than that?
this width of the calyx, sir. That
Width of the infundibulum.
yes,
Infallible.
yes.
Okay. Now, how is the width of infundibulum in upper pole and whatever is seen in the middle pole? Doesn't look very, very significantly dilated. So though the stone bulk is high in this patient, probably I would aim for a ECRS with mini perk. Okay. So don't rely solely on the stone bulk. Also look at the infundibular diameter. Your tract should always be smaller than the maximum infundibular diameter that you get after installation of the contrast.
Yes.
Okay. Now, if you decide to do say not ECRS but only PCNL, then can you go to the plain X-ray KV, please? The initially which was shown. Yes. Now with this X-ray, tell me which calyx would be your favored calyx to enter?
Sir,
Type PCNL in this patient. From where will you enter this kidney?
sir, this will require, sir, at least two punctures, sir, minimum to clear the stone, sir, and the majority of the bulk in the pelvis and in the upper calyx, sir. So, first puncture will be, sir, superior calyceal puncture, sir.
So superior calyceal means what? The medial one or the lateral one?
Sir, better I will be able to decide on RGP, sir, depending upon the delineation of the calyx, sir, on RGP.
So usually in Staghorn stones, the upper calyx has the advantage that from upper calyx it is possible to go to the renal pelvis. It is possible to go through the all components of lower calyx. But in this patient, the way the system is, it's a reasonably bifid system. The angle between the upper pole infundibulum and lower pole infundibulum is again quite acute. So it may be very difficult to come from upper pole to lower pole. Means, as you rightly said, finally on table things can be different. So if I were to do this patient, I would probably be ready for not two, but probably four punctures. So practically every calyx may need a separate tract in this patient. Going from one to other may be very difficult. But obviously you take call about the next tract after you have made the first tract.
Yes.
Now, suppose you have made the first tract in the upper calyx. From upper calyx tract, you have got the upper calyx, infundibular stone and the renal pelvic stone. you are unable to get the lower calyx stone. So how will you make the lower calyx tract? Now you already have one tract in the calyx. So how will you fill the system to make the lower calyx tract? You understood my question?
Yes, sir.
Hmm.
I will instill the contrast from the upper calyceal tract, sir, and I'll identify the
So how will the contrast stay there? It will leak out of the Epla sheath.
or we can do, sir, through endoscopic guidance puncture, sir, endoscopic guide, like ECIRS.
Anything else?
Stone guided puncture, sir, in this case.
Anything else?
There are two different things you can do. Is it necessary for you to do only one puncture at the same time?
No, sir, if after doing the RGP we are able to make out, sir, if we are sure we will it will require 2-3 punctures, we can put punctures before starting the procedure only, sir.
So
So
you
that,
can pre-place the wires in
yes,
whichever tract you feel would need dilatation.
yes, sir.
Then dilate one tract and then sequentially dilate the other tracts if necessary. If not needed, then those wires can be pulled out.
Yes, sir.
Okay, so that was option number one. Option number two was, as somebody wrote, that you can put a Amplage dilator in the Amplage sheath and then instill contrast. It still leaks, but okay, that is also one
It
option.
Can I, Maheshwari ji, हमारा एक
Yes,
innovation.
बोलिए sir.
What we do is that 2 cc syringe, 5 cc syringe. Okay. Lower lock. There is a rubber, black rubber in front of piston. So we remove this piston, which fits beautifully on the emplas. So whichever emplas you are using, if there is no guide wire, okay, you can just fix it on it. And if even if there is a guide wire, we can put a small needle, like how we put it in a Foley's catheter to bring
Get
out
it through
the
the rubber,
yeah,
yes.
the two, and there is a 100% no leak.
Perfect, sir. Wonderful.
I will. I'm thinking of making one Jugaad lecture on that. How to, in the difficulties, have a different instruments to be used. So that is another way. And it's very nicely we can demonstrate all the calyx and if there are any residuals. Okay. So anything new trick, Maheshwari ji, apart from this?
No, sir. New trick के अलावा what the standard things you should talk about ultrasound puncture here, and last you should talk about stone guided puncture.
Yeah,
So pre-placed wires, blocking
correct.
the Epla sheath in some way and filling the system, ultrasound puncture, and stone guided puncture. So that is how you would go. You cannot be changing plan to ECRS after you have made one track. Means that is something which you will need to plan beforehand. But if you are planning
Correct.
only PCNL here, then these are the 4 ways of making the second track.
Yes.
Yeah. So Anuj, now you have done started this surgery. How much time you will give? Like in QRP, you said
What
na, that
sir
I
is
will not
asking is
proceed.
there maximum nephroscopy time that you will stick to?
Sir, normally we stick up to 90 minutes of duration, sir, for PCNL. And it also depends upon the patient hemodynamic status. If patient bleeding is more during the procedure, so we have to abandon the procedure before time also, sir.
Good.
Hmm.
I think sir, ठीक है, we can move ahead. So very interesting report that they write non-uric acid calculus. Gaurang bhai, you're there?
Yes,
Yeah,
sir. Yes, sir.
I think this is Dr. Jankaria, na? He gives quite elaborated depending upon the Hounsfield units and other factors,
Yes,
what they
yes,
see.
yes, yes. I think should we move to the next case, sir?
Yeah. Brijesh, next case.
अनुज बाय और थैंक यू तो बोल दो.
Yes, sir. Actually, network connection was.
I'm just pulling your leg.
Yes, sir.
ऐसा केस खत्म होते से आपने इमीडिएट बंद कर दिया.
No, sir. Connection was poor, sir. Thank you very much, sir.
चलिए, टेक केयर भाई, एंजॉय.
Yes.
Who is answering now?
Sir, Rahul.
Okay, Rahul, and along with you, anyone else is there?
Sir, no, sir.
Okay.
Sir, should I start?
Yes.
A 77-year male patient with the chief complaint of difficulty in passing urine since 3 months. Sir, I would like to elaborate the chief complaint. The patient was apparently asymptomatic 3 months back when started developing difficulty in passing urine with poor flow, increased frequency every 3 hours, with hesitancy and urgency, with sense of incomplete voiding. Symptoms were insidious in onset, gradually progressing with no specific aggravating and relieving factors associated with straining during passing urine and nocturia 3 times a night. IPSS score is 30. Then, sir, I would like to ask the patient about the negative history, like whether patient is having any lithiuria, history of hematuria, then any other symptoms like uh, previous history of any endourological procedure or any catheterization or any history of facial puffiness, exertional breathlessness, lower limb edema. Uh, so there is no history of backache, bony pain, and weight loss. There is no history of burning, maturation, and no history of hematuria or lithiuria, and abdominal pain or vomiting. Then, sir, I would like to ask patient about the personal history and past history as well as family history of the patient. Sir, past history known case of diabetes and hypertension on tablet metformin 500 milligram BD for last 12 years and tablet Telma 40 mg OD for last 10 years. Family history not significant. Personal history, he takes mixed diet, appetite is adequate, regular and normal bowel and bladder habitat, sleep disturbed due to the nocturia, habit, no, non-smoker, non-tobacco chewer, non-alcoholic. Then, sir, I would like to proceed with the general examination of the patient. I would like to explain the patient and I would like to examine the patient in well-lit room in supine as well as in standing position. Then I would like to see the patient's vitals, pulse, blood pressure, then sir, body mass index, colonoscopy score, as well as, sir, I would like to see any cyanosis, pallor, icterus, uh, clubbing, lymphadenopathy, or edema. Head to toe spine examination in this patient appears grossly normal. SpO2 98% on the room air, and
Rahul,
body
speed
mass.
it up. Just say everything is
Yes,
normal.
sir. Your general
आपने
examination
कब
appears
लास्ट
normal.
ओपीडी में क्लबिंग देखा है, मुझे बताइए.
No, sir.
फिर
Sorry,
क्यों
sir.
आप ये सब बात कर रहे हो?
Sir, local examination appears normal. Per rectal examination done in same position also appears normal, in which prostate grade 2 enlarged, firm inconsistency,
No, go
and
back.
per
DRE
abdo
is important in
examination.
this patient.
Yes, sir. There is no fistula, hemorrhoids, anal tone normal, prostate grade 2 enlarged, firm inconsistency, smooth surface, non-tender, median sulcus palpable, rectal mucosa mobile, rectum empty, no blood on gloves. Then, sir, per abdo examination and other systemic examination in this patient appears normal.
Now, so what is at the end of this examination? What is your clinical diagnosis? What do you think of? Can you just summarize
Sir,
and tell us?
Sir, 77-year-old male patient with mixed urinary storage and voiding symptoms, and digital rectal examination appears normal. In this case, sir, I would like to keep my differential diagnosis is bladder outlet obstruction may be due to benign or malignant cause. One, then, sir, I would like to keep neurogenic bladder, as well as, sir, I would like to keep in mind stricture disease of urethra. Sir, these are my provisional diagnosis as per the points in history as well as point on examination. Then,
Okay, so depending, so again, tell me what are the important differential diagnosis? One, you are saying that is a bladder outlet obstruction. Maybe
yes, sir, maybe due
pros-
to the benign cause, or maybe it may be due to the malignant cause. Then, sir,
yeah.
neurogenic bladder as well as, sir, stricture disease of
Why you are saying
urethra.
neurogenic bladder?
Sir, patient is having mixed urinary symptoms, as well as he is a 77-year-old patient with diabetes having 12 years of duration. So that one clue I would like to keep as a differential diagnosis.
Is diabetic cystopathy same as neurogenic bladder?
Sir, no, but due to the peripheral neuropathy, it may one of the contributing factor to the diabetic cystopathy, as diabetic cystopathy is a combination of neurogenic, myogenic, and hyperglycemic component. So
You only
because of
you
that,
only
I
give
have considered.
you only give the chance to the examiner to tell you to ask you what is the difference between diabetic cystopathy and neurogenic bladder. When you're finished
Sir,
examining the patient, then you're telling neurogenic bladder, and then you're telling he's 77 years old and has got diabetes. Okay, you're doing well, but you have to keep your mind alert. Hmm?
yes, yes, sir.
Rahul, the anal tone is normal, perianal sensations are present. There is no
Absolutely.
neurological feature in this patient. And diabetic cystopathy, don't call it neurogenic bladder. Diabetic cystopathy is different, neurogenic
Yes,
bladder is different.
yes.
Diabetic cystopathy may be a presentation of peripheral neuropathy component of diabetes, but it still doesn't come under the gamut of a neurogenic bladder. When you say neurogenic bladder, I start
Okay,
thinking about either central or peripheral nerve lesions which cause change in the bladder function.
okay.
Okay. So, why
Yes,
why
sir.
did you consider stricture in this patient?
Sir, the patient is having a poor flow, as well as, sir, that poor flow also uh, may be due to the obstruction of the bladder. So there is as such no points in the history of the patient, but I would like to keep as a down in the differential diagnosis.
So again, I would suggest here that if a patient presents with only voiding symptoms and no storage symptoms, that is the time you may consider stricture as a possibility. But there should still be some associated history like instrumentation, catheterization, trauma,
Yes.
urethral infection. If none of these are there, and if patient also has storage symptoms, then stricture becomes less likely.
Yes, sir. Yes, sir.
चलिए,
Another
ठीक.
thing is, Maheshwari ji, I believe in these exams, when they went to Nadiad also, they were saying that he is an old man and there is no any other history. You should not consider as a stricture.
I
But
100% agree, sir.
yeah, yeah. But I think in practice, we always keep in mind because 74 years old male may not actually tell us what he did when he was young. So, and you must also have agreed that so many times when you go inside and see, you will find a picture. So, at least for the practical purpose, I feel that we should keep it in.
Fair,
Yeah,
sir.
go ahead.
Yes, sir. Complete blood count appears normal. His serum PSA is 0.28 and 2D echo appears normal. And other investigations, serum creatinine and HbA1c is in the normal range. So then I would like to see the urine routine microscopy also, sir,
Rahul, hold on.
along with
Before you
the
proceed, would you have asked for PSA in this patient?
sir as a not for screening procedure, but as a opportunistic procedure, opportunistic diagnostic investigation. I would like to, as this patient is old age 77-year-old patient, I would like to do serum PSA as a opportunistic investigation, not a screening or diagnostic investigation.
Will this be called as a opportunistic investigation? Or means what is screening, what is opportunistic screening, and what is investigation?
Sir, screening is done in as US task force suggests in between age group of 55 to
No, no,
69
what do
year
you
of
mean by
age.
screening? What do you mean by screening?
Screening, sir, screening is a test which done in normal population,
So patient who does not
normal
present with
individual
urinary symptoms, you go to some
symptoms.
club or mohalla and evaluate everybody more than 50 years. That is screening. Opportunistic screening is when the patient comes to you for stone and then you do PSA. Okay.
Yes,
But in
yes,
this
sir. Yes,
patient, the patient has come with lower urinary tract symptoms. So PSA becomes a necessary part of investigation. So this is not opportunistic
yes,
screening. This is an
yes,
indicated investigation.
yes, sir.
So you have to say, because this patient has come with low urinary tract symptoms, I would definitely want a PSA in this patient.
Yes, sir.
चलिए
Then,
आगे क्या चाहते हैं?
sir, I would like to do ultrasonography of abdomen and pelvis. After seeing the abdomen and pelvis, I would like to order uroflowmetry in this patient.
बताइए सब.
Sir, urine routine microscopy and appears
Culture
normal,
growth.
I think, sir. Sir, yes, sir. Uh, these are the which appears partly distended. In the bladder, there is a bladder. There is a echo echogenic shadow as well as the post-acoustic shadow is seen in the bladder. Bladder wall appears normal. There is no obvious any other pathology in this bladder plates. And sir, I would like to uh, see the sir renal images also, sir.
You don't want
And
to
in
comment on the
this,
prostate?
sir, yes, I would like to comment on the prostate. Sir,
Mm.
prostate appears, sir, prostate in both plates appears normal, sir. It's not look obvious prostatomegaly. But sir, I would like to uh, take volume of the prostate in a USG machine that will better give the idea of the volume of the prostate. But on obvious, there is a peripheral calcification is seen in the prostate. Uh, Other things are appears normal, sir, in prostate. Sir,
Do
I
you
would
think
like
there
to
is
see.
significant IPP in this patient?
Uh, yes, sir, mild IPP in the median lobes.
So there is mild. So again, the way I would read this is that this is a sonography showing vesicle images. Bladder is suboptimally full.
Yes,
Bladder wall thickness looks normal. There is mild prostatic enlargement with small IPP and a large vesicle calculus seen, solitary large vesicle calculus seen.
yes, yes, sir.
Okay. Do you have images of the upper tract? And you can also give the report. Okay,
Yeah.
as far as sonography is concerned, you can always ask for the report.
Yes,
Yes,
yes.
sir. Sir, this is the ultrasound report of abdomen and pelvis. In this report, vesical calculus, single large mobile around 3 centimeter with right and left kidney appears normal and prostate is 42 gram with pre-void 197 cc and post-void is 1110 cc.
Okay. Show him the uroflowmetry.
Sir, this is uroflowmetry. In this total voided volume is 210 and Qmax is 13.7 ml per second with voiding time 62 seconds. Average flow rate is 5.4 ml per second. Sir, in this, there is a obstructed pattern seen on the Euroflow graph, which is suggestive of bladder outlet obstruction.
What is the difference between flow time and voiding time?
Sir, voiding time start when a command is given to the patient, but flow time is when actual patient start the urinary flow. That
So
time is
voiding
called
time
as
is flow
a flow
time plus
time.
the hesitancy time.
Yes, sir.
Okay, right. What next?
And sir, as the patient is on the USG patient is having vesical calculus as well as prostate moderate grade of the prostatomegaly. I would like to counsel my patient regarding the uh, options of treatment in form of cystolithotrypsy and uh, sir, in the form of cystolithotrypsy with pneumatic as well as laser cystolithotrypsy. After that, sir, I would like to assess my patient again, and if patient is having persistent voiding symptoms as well as obstructive symptoms, then I would like to counsel the patient regarding the medical management for the prostatomegaly, and I would like to follow the patient. After that, I would like to uh, give the further treatment for the prostate.
So let me ask you the alternative. Suppose if I say that I will like to treat this patient first for the obstruction and see whether he is improving or not, and then I'll decide my line of treatment, whether to do stone surgery only, stone and prostate. Second is you say that I will do only cystolithotripsy and then I will give patient medical line of treatment. I will evaluate him and then decide regarding the QRP. And the third, I'm saying that you would like to do cystolithotherapy along with QRP. Now, which option you want to give and why?
Sir, I would like to give the first option, sir. I would like to go for cystolithotherapy first. After that, I would like to go for the medical management for the prostate. I would wait for the treatment to uh, take its effect, and after that, I would like to assess the patient, sir. But if a patient is having severe symptoms, as well as patient is insisting on both the treatment, then I would like to go for cystolithotripsy as well as transurethral resection prostate.
So now you tell me in which cases he will give, he will do only cystolithotherapy and do a QRP later on if required, and in which cases we will do both together.
Sir, severe obstructive symptoms associated with hematuria, and sir, in that case, I would like to go for cystolithotripsy and TURP.
What has hematuria to do with TURP?
Sir, as such, there is no indication
Why did you
which,
say that?
sir, uh, due to the stone irritation and due to the mucosal erosion of the stone, that will
Then
lead to
that
the
means
hematuria and
hematuria plays
obstructive
no role
symptoms.
in your decision making for prostate surgery.
Yes, sir.
So, but you definitely said, no, because if patient has hematuria, I'll do TURP.
Sir, I would like to, when I am going for cystolithotrypsy, I would like to see the prostate enlargement,
Much
whether
better.
it is obviously enlarged and or median lobe is enlarged, which is obstructing the bladder neck. Then I would like to take the decision about the TURP. Sir.
Now, you see, in this patient, the way I would think is that this patient has thickened bladder, there is enlarged prostate, there is significant IPP, there is flow rate, except for one spike of 13 millimeter, overall flow rate looks flat. There is a prolonged void. There is very significant post-void residue of 110 ml. I see no reason for doing these two things separately. This is a patient who would need to be planned for cystolithotherapy with prostatectomy under same anesthesia. What is against this plan?
Sir, we don't know the exact obstructive pattern, whether obstructive symptoms are due to the stone or obstructive symptom due to the prostatomegaly. Before doing any invasive procedure on the prostate, we should try the medical line of treatment. After that, and patient is 77-year-old.
So how does that make a difference?
Sir, over a period of time, as age progresses, there is slight increase in the prostate, that is the urethra, and that can be taken care due to the medical management. After that, we can go for the sir, surgical management.
Sorry, I couldn't hear you, but
Okay, so Anuj, let me ask you. Suppose this patient doesn't have stone. Okay, and now he has got,
Yes, sir.
these are the findings. What you will do?
Sir, I would like to give the first conservative line of treatment. Sir, behavioral modification, limiting the fluid, dietary modification. Along with that, I would like to give medical management in the form of alpha blocker as well as 5-alpha reductase inhibitor. Then, in a period of time after uh, of 6 weeks to 12 weeks, I would like to assess the patient how his IPSS score is improving or deteriorating. On that basis, I would like to take my further decision.
Fine. Okay. So now suppose if you want to, now you're near the exam. If you are saying that this patient, you want to stage, you want to, so you can say like that, that this patient has got stone and these are the things. If there was no stone, I would have given him the benefit of just saying medical management. And see, in this case, again, residual urine and his symptoms may be exaggerated because of the calculus disease. I will like to stage it and then see if he is not improving. Okay, then I will like to do T1.
Yes, sir.
Or as Dr. Maheshwari has said, if you decide that you want to do both together, then you have to justify again in a different way. So whatever you say, you have to justify. Understood?
Yes.
Dr. Hudedar is there. Hudedar ji, any suggestion from your side?
I agree with simultaneous this one means cystolithotripsy plus TURP.
Fine. Okay, Anuj? So there in the exam, you have to be, whatever you say, see, there are many examiners who will agree with your view. There are many examiners who will not agree with your view. But if you can justify your answer, they will not categorically will say that you are wrong. Because both the things are okay. Because I have seen
Yes, sir.
in one of the exam, I have seen many senior people when such a case had come, they said, no, you should do only cystolithotripsy, and then later on, if the patient is, because there are chances that 100 post-war residual urine will come down, his flow, which is at present obstructed, may improve, and he may not require, TURP for a longer period of time. So there are examiners
Yes.
who you will agree with your view, but you have to justify. Okay. Now
Yes.
this is a stone
Yes, sir.
X-ray. How will you remove this stone?
Hello, sir.
Yeah.
Hello. Sir, I'm not your question, sir.
Sir asked, how will you plan treatment for this stone? Now we are not considering prostate. How will you plan treatment for this stone?
Sir, sir, there are options for this for clearing the clearing this stone. Sir, there is a perurethral cystolithotripsy as well as percutaneous
No,
cystolithotripsy.
you tell us
Both
what
options.
you are going to do. What you want to do
Sir,
now. Tell.
I would like to do laser cystolithotripsy per urethral for this stone. I would like to explain the patient, and I would like to take the patient in the operation theater, give the spinal anesthesia, and at the time of anesthesia, I would like to give IV antibiotic. Then, sir, I would like to uh, use a sir of 24 sheet size, in which I would like to use a laser guide. With the help of laser guide, I would like to do the fragmentation of the stone in partially filled bladder. And after that complete fragmentation, I would like to evacuate the stone through the sheath with the help of helix evacuator. And then I would like to place a large bore catheter for the drainage.
Now I want to ask you a question. Why you want to do laser? Why
Sir,
not lithotripsy? Pneumatic.
sir, pneumatic also good, sir, with the same stone clearance rate. Is
So another question is,
more in case of pneumo. Sir.
the second question is, if you are going to use laser, how much time you are expecting that it will take?
Sir, around 60 to 90 minutes, sir, I would like to finish off this stone.
So that 90 minutes your sheath is going to be inside. Then why?
Yes, sir.
My question is, why you don't want to do pneumatic?
Sir, pneumatic with the considering the fact that sheet time and laser use time.
So in exam now you say that, sir, I will like to use combination if needed.
Yes.
I will start with laser because it is a very round stone. There are chances that with my pneumatic I may not be able to steady the stone and I may not be able to break it. So
Yes.
with a laser you may make multiple holes in the stone, and then with the pneumatic you may be able to break it. This way your uh, breaking will be much faster than only with laser.
See,
Understood?
yes. Yes,
So
sir.
that is number one. Second thing is, will you like to, in this case, will you like to do percutaneous suprapubic?
Yes, sir. The stone, as looking the stone size, it will clear the stone in less amount of the time, and it will give same result as a laser lithotripsy.
No. I am asking you in this case whether you will think of doing suprapubic approach or you are not thinking of doing. You will not give
Sir,
that thought.
sir, I'm thinking of both the line of treatment, but uh, I would like to go for laser lithotripsy through per urethra.
Okay,
So, Rahul, what
fine.
you need to say here is that PCCL will be done for large multiple urethral calculi where the urethral instrumentation time is likely to be longer. But for the small single stone, you would be able to do it per urethral very easily. So here you do not need PCCL.
Okay, sir.
No, this is I want all the students to please go through, answer this time. Whatever Dr. Maheshwari has said. See, you have to be very precise in exam, how to answer. And once you answer that particular way, then the examiner will be happy and he will not ask you further questions. If you say like this, examiner is not. Otherwise, he will say, okay, so which are the cases, when you will do it, why you don't want to do in this case. So be precise and be clear in your thoughts. And this is what you have to learn from our classes and exam how to answer. Okay? Fine.
Yes, sir.
Okay. So, Pankaj bhai, can we go through the third case?
Surely, sir.
Yeah. Bridget,
Thank you, sir.
see,
Thank you, sir.
this is, yeah, thank you. See, to all the students, we have completed our fifth session and we have discussed every case. So now we are preparing you only for the exam, and that is why we are not covering the whole, subject. Otherwise, only on this case we can discuss for 2 hours. So we want you to train so that how to answer in exam for a particular case. When you are presenting this case, in this patient, what you will do. That is very important. And that is what we want you to understand. Okay? Fine. Go ahead, Bridget. Who is answering now?
Sir, I'm answering Dr. Hamid, sir.
Yeah, I mean, all the best and do
So,
best. Okay?
thank you. So,
Yeah.
this is 58-year-old female came with a complaint of pain in the left flank region since 15 days and one episode of fever before 1 week. So, I would like to ask about the onset of the pain, then severity of the pain, any migration, radiation, or aggravation, or the relieving factor associated features like nausea, vomiting. The patient was relatively asymptomatic before 15 days when she developed pain over the left flank pain. Pain was dull aching in nature, gradually in onset, radiating to back, gradually progressing, and has increased since 10 days, associated with nausea and fever. Fever, one episode since 1 week. No specific aggravating factor, relieved on taking analgesic and antipyretic. History of similar complaints 2 months back. No active treatment taken at that time. So the negative history, there is no burning micturition, no history of vomiting, no history of lithuria. This so no relevant yeah. So no history of previous instrumentation or catheterization,
There
no
was
history of
abdominal pain and fever. This was a typical error. There was abdominal pain and fever was there.
yeah. So I would like to ask about the personal history, family history, past history of the patient. The patient is a known case of diabetes since 10 years on regular insulin. No history of previous surgeries. Family history, nothing significant. Patient is menopausal and personal history is not relevant according to the case. The general physical examination is uh, grossly normal. So, local examination patient was examined in supine position with implied informed consent. With the exposure from the nipple to knee, adequate roomlet, external genitalia normal, all hernia orifice normal, rest findings are normal. Per rectal examination in Uh, I would not do the rectal examination in the female patient.
It's a bold
Per
thing
app.
to say.
Sorry, sir.
That's a very bold thing to say. Why would you not do a DRE in a lady?
Sir, as the case is more toward the flank pain, it is not indicated to like. I will do the per vaginal examination, but there is no clear-cut indication of digital rectal examination in this patient.
Chali.
Per abdomen patient examined in the supine position with implant informed consent, with exposure from nipple to knee in adequate room light, inspection umbilicus centrally placed. So on in the local examination, only finding is there is a mild tenderness present over the left flank pain, left flank region. No increase, local increase in the temperature, and other systems are normal. So I would like to ask for the CBC, RFT, LFT, and urine routine and random blood sugar and HbA1c of the patient.
Before that, just tell me what you are thinking. What is there in your mind?
So, sir, this is a 58-year-old female with a flank pain, left side flank pain, which is gradual or dull aching in nature, gradual in onset and dull aching in nature. I would like to
Has a fever.
patient has a fever. So I would
Fever.
like to
And patient is
patient is
Diabetic.
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 Yeah. So I would
Who
like
else is
to
answering? Someone else is also
Sir,
there?
Dr. Solai from Gangaram Hospital, sir.
Okay, fine. So no, that I should know. No? I can ask both of you. Fine.
I
Okay.
would like to keep my differential diagnosis. It may be infected hydronephrosis secondary to the PUJ, or patient may have
PUJ,
pyelonephritis.
directly PUJ.
Sir, infected hydronephrosis secondary to PUJ.
No, that is your primary diagnosis is PUJ.
Dr. Hamid, do you diagnose PU junction obstruction in a 58-year-old lady? Would that be the first diagnosis? Or you would be surprised if a 60-year-old lady comes with PUJ?
Yes, sir.
So what would be more common in this patient
The
at this age?
file, since the patient is diabetic and have a history of flank pain and fever, the most common finding will be pyelonephritis, which can be
Due to?
which can be acute pyelonephritis, or since she is diabetic, so I can also keep the emphysematous pyelonephritis in my.
You see, patient is
No,
not sick at this time. You just said that hemodynamically she is normal. Will EPN present in a patient who is hemodynamically normal? Possible, but not very usual.
Yes,
So what is
but
more common in this patient?
see, you said,
pyelonephritis.
huh?
So
you are saying
why does
pyelonephritis.
pyelonephritis happen in a diabetic patient?
Papillary necrosis, sir.
Papillary necrosis.
Yeah.
Very good. So
Fine.
here we are dealing with left obstructive uropathy with infection, which could be related to papillary necrosis, stone, or any other cause.
As this
Yes.
patient is 58 years old, we can also think of cervical malignancy causing obstruction, sir, or any malignancy causing lower urinary tract obstruction.
So you see, don't really try to specify this because we really don't want our discussion to go in that line at this time.
Okay, sir.
So we will just leave it by saying that obstructive uropathy, most likely papillary necrosis, stone disease because that is common, and maybe some other cause.
Yes, sir.
Okay, so now what next?
So apart from the blood investigation, I would like to do a urine routine and culture and USG KOB with as an extension of my local examination.
Yeah. Bridget.
Please show the next slides.
Bridget. Okay. Show them the ultrasonography. Yeah, the
So
first
in
cells
this
are like,
urine, the relevant finding is there are the 60 to 65 first cells with 10 to 12 RBCs and the bacteria is present. I would like to go with the urine culture. Urine culture is suggestive of 10 raised to power of 5 called CFU per ml, suggestive of Pseudomonas aeruginosa.
so you will decide the line of manage antibiotic. Correct?
Yes, sir.
Fine. So that later on you can tell us which antibiotic you want to do after seeing the other investigation.
The kidneys, the right kidney is a 16 calculus in the left renal pelvis, causing hydronephrosis. Multiple other non-obstructive calculus, less than 10 seen in lower calyx. Bladder wall thickness is mildly increased. There is no abnormal internal echos in the bladder. The bladder volume is pre-void 140 and post-void less than 10 cc.
Okay.
So the sonography significant finding is the non-obstructive left-sided renal calculi.
Why
So next, what you want?
non-obstructive? Because there is hydronephrosis.
You are saying non-obstructive?
No, sorry, sir. Hydronephrosis with the 16 calculi in the lower calyx.
So
Causing
left-sided
hydronephrosis.
obstructing calculus with mild hydronephrosis.
So it's renal pelvic stone only, sir, with causing the mild hydronephrosis.
So it is causing obstruction at that level, huh?
Yes.
You saw the earlier with
Yes,
the
sir.
Staghorn, even though it
Yes,
was
sir.
from the pelvis going into all the calyx, still there was no hydronephrosis. Right or wrong?
Sir.
And in this case, there is a hydronephrosis. Means what? That this stone is definitely causing obstruction, maybe intermittent at the Pew junction. Right?
Yes, sir.
Okay. Now next, what you want? Who is answering next?
Dr. Sole, sir.
Dr. Sole.
Yes, sir. Sole Raj.
Sole Raj. Okay, sir. So now what you want to do?
Sir, as this patient
You
is
want to
having
do DJ stenting or you want to do PCNL? What you want to do? Lithotripsy? What you want to do?
at this patient is actively having infection, so we will start with her on antibiotic and then do degesting, sir.
Sir, I would
Without
like
doing
to
any other investigation?
further evaluate the patient with the CT scan.
Okay. Fine.
Preferably CT urography.
Okay. Justify why you want to do CT urography.
But as the sonography is showing the 16 and the 10 calculi, the patient may, like, if patient may need some sort of intervention that can be planned on the basis of the CT urography. And secondly, I can get the anatomy of the anatomical details based on the CT urography. And yeah.
So, Hamil, what is more important criteria while deciding whether to give contrast or not? This patient, as somebody has written, this patient has borderline elevated creatinine. She's a diabetic. We are dealing with obstructive system with infection. What is the role of contrast study at this time?
See, again, you have to justify. If you are saying that you want to use contrast, you justify why you want to use contrast.
For the better anatomical delineation and sub.
So you see, you people in both cases have said about better anatomical delineation. NCCT with a good quality CT machine, means if you have a 64 or a 128 slice machine, gives a fairly good anatomical delineation even on a plain CT. Contrast CT does not give you functional assessment as a intravenous urography used to give, because CT has a very high pickup rate of contrast. You will see opacification even when very small amount of contrast comes in PC system. In a stone patient, at least as per guidelines, there are very few indications for doing a contrast CT. From exam point of view, I would suggest that give this answer based on who the examiner is. Most of the senior examiners may want a contrast CT, but you can definitely justify doing stone treatments without contrast CT. You will always do RGP whenever you are doing a interventional study. So anatomical information you get there. Functional assessment can be gained by looking at the cortical thickness based on the creatinine levels. As it is in presence of acute obstruction, you do not delineate function on any contrast study. So doing contrast study at this time really makes no sense.
Okay, sir.
Fine. And in case if you, by chance, if you say that yes, I will like to do contrast, then you can always justify saying that it will give me, help me in seeing the function, whatever it, it delineates. Second thing, whether any, cortical, any lesions are there, which will be seen very nicely on contrast, as well as the extrarenal pathology. And if there is a papillary necrosis, and if there is some obstruction lower down in the ureter, that also will be seen. So, as a guideline, Dr. Maheshwari said, most of the people, like, when we come as an examiner, we will not expect you to say contrast and end. Okay, I repeat.
Okay, sir.
But in case if you say, just remember how to justify.
Can we say renal abscess or pyelonephritis to be delineated?
Yeah, that's what I'm parenchymal lesions and extrarenal.
You see,
If there
renal
is any
abscess
extra
you would have
position.
suspected based on sonography.
Yeah.
With the sonography normal, what is the possibility of finding a significant renal abscess?
Yes, sir. Least chance.
And most of the time is a small multiple abscesses which can be seen even without contrast also. But by chance, if you say like that, you have to justify, whatever the best way you can.
Okay.
Okay, fine, sure. Brijesh, Brijesh, huh.
So these are the axial images of the CT abdomen and pelvis, suggestive of left kidney parenchymal hypodensities, and in the PC system as well, sir. Right
Okay.
kidney looks normal. Can I go get the previous image back? Just yeah. The bladder looks normal on this CT. Yes, sir. The coronal images.
Now tell me on the left hand side, you can't see
There
the
is
hair?
Yeah, sir. Air densities are seen on the left parenchyma and the PC system.
Hmm. Fine. Okay. So looking at this now, what else is there? Stone is also seen, na? On the left hand side.
Sir, I
A
can't
small
see
stone
the stone, sir. No, sir.
here and down.
No, I'm not able to appreciate the stones, sir, on this films.
This is a very small stone. Actually. Okay. Show the report. Read.
Left kidney is contracted and shows area of cortical thinning, possible scarring. Few locules of air foci are noted in the interpolar region. The hyperdense foci with central hypodensity is noted at the interpolar region, measuring 0.8 centimeter. Possible calculus calicial sloughing. Tiny calcific
Hmm.
foci are seen. 2 mm is noted at the inferior pole. Air locules are also noted within left ureter. Mild perinephric fat stranding is seen on left side. Right right kidney is normal. Urinary bladder distant but shows no intraluminal filling defect. The hypodense lesions of 1.7 into 1.2 centimeter noted at the inferior pole of the spleen, possible abscess. Rest other urological findings are normal, sir.
Okay. So now what you want to do? Do you think you would have been wiser with the contrast?
Yes, sir. I can like appreciate any focal uh, hypodensity areas on the renal CT urography
Okay.
or the wedge shape area
Fine.
on the CT
Yeah.
urography.
Okay. Who else is answering? Second guy?
Solai, sir. Dr. Solai.
Solek. So what you want to do? What you think now? What is your diagnosis?
Sir, now the features are consistent with the emphysematus pyelonephritis of left kidney with creatinine of 1.39 and patient is poorly controlled diabetic. So this comes under class 2 of emphysematus pyelonephritis, which can be managed with antibiotic and degestant or PCM, sir. So I would go for degestanting and antibiotics, sir.
Mm-hmm. So what are the class? Tell me.
Class 1 air foci near pelvic calcium system. Class 2 in the intraparenchymal region. Class 3A is extra parenchymal like till perinephric region, and class 3B is beyond Geroda's fascia. Class 4 is bilateral kidney or retroperitoneum.
Okay. So your according to it is class 2, correct?
Yes, sir.
And the patient is hemodynamically absolutely stable.
Stable.
Even the WBC count is okay. First
9,000.
tells us that 60 to 65. So in this case, which antibiotic will like to give?
Sir, our culture sensitivity showed colistin is intermediately sensitive and phosphomycin is sensitive, sir. So colistin 1 million units TDS, sir. We can give.
What is the side effect of colistin?
Don't know, sir.
You don't know. I will tell you, in so many patients we have seen, it is, according to me, it is worse than even amikacin. So many times, whenever we have started colistin, the creatinine has started increasing. Patient has started going into CKD. Now this patient already creatinine is high, patient is diabetic. There are chances patient has got a diabetic nephropathy, and you have got a phosphomycin in your hand. Still, you like to give colistin?
Then phosphomycin.
And you are saying this patient is otherwise well controlled, correct? Except the pus cell and CT finding, like Dr. Maheshwari said, that he will never think of, from the history, he will not think of emphysematous pyelonephritis in this patient.
Absolutely.
So it is appearing like an incidental find. So in this case, you can definitely go ahead with the phosphomycin. Phosphomycin is also a very good drug. Yes, if it is uncontrolled and if you need, then colistin is the drug of choice.
Okay, sir.
So what you will do? I'm giving you option. I will only give antibiotics till everything becomes normal and forget the patient. Number two, I will give antibiotics and I will do digest stenting. And later on, because they are saying there is a stone, I will do RIRS. Number three, I will give a good antibiotic. Once the patient is absolutely okay, I will do RIRS and then I will, at that time, I will do digest.
Sir,
one of them. Yeah, tell me.
First, we'll give IV antibiotics and then like we'll give phosphomycin and then do stenting, sir. Because patients HbA1c is 8.9 and
No, so when you're doing phosphomycin, you're doing antibiotic, a good antibiotic, you are definitely going to cover up the diabetes. Na? So you're going to treat diabetes and you're definitely going to treat the infection. So you want to do 3 procedure or you want to do 2 procedure? First of all, tell me whether you want to do RIRS or you don't want to do RIRS.
RIRS is sir 0.8 mm, like 8 mm calculi is there. It can obstruct anytime. So but
yeah, tell me. No.
We can go for RIRS later, sir. So now we have to do stenting and then like we will.
So how wise? No, you tell me why you want to do stenting.
Sir, as this patient is hemodynamically stable, I will monitor the patient with the IV antibiotics and with the repeat investigation. And as there is no clear-cut hydronephrosis, I will just keep on continuing with the blood test and monitoring of the patient hemodynamically. If the patient progress on these antibiotics and the symptom progress and his her parameters derange, then I would consider for the DJ stenting or deobstructing the system.
And what about this stone? You don't want to do anything.
Sir, at present, there are the air foci in the system. At present, I don't want to do any stone surgery.
Okay, then when this air foci will go away?
Sir, usually it takes time of 4 to 6 weeks or maybe longer.
I have treated patients after 6 months also I have seen there are air foci. Now after giving all the treatment and everything, when the first cell also has decreased, but air foci are seen. Should I consider that as a bad omen and not to do anything?
Sir, as the CT is suggestive of the left kidney is contracted and the patient is hemodynamically stable and the stone is non-obstructive, I can observe the patient.
So you want to wait till the patient becomes hemodynamically deranged and stone obstructs and causes actual emphysematous pyelonephritis. See, I am just giving you thought. I'm just giving you a thought. What can happen? Number one, you treat her and follow up her. There is one option to you. Every monthly you tell her to come, okay? And 3 monthly you can ask her to come with sonography, otherwise urine, and keep on treating her. And do Any intervention when you think that stone is going to obstruct or it is coming down or it is causing infection or you do digestion. Second thing in this case, you say, no, I want to do digestion. Then tell me how you are going to be wiser. What benefit you are getting by putting a digestion?
Sir, it will lead to the passive dilatation of the ureter and clear the infection as well. So if we have to go in future for the RIRS, this RIRS would be like more uh, accessible or easy, approach like accessible for the stone if we have to proceed with the RIRS in the future.
Okay, so now tell me your line of treatment in this patient.
Sir, at present, I would monitor the patient hemodynamically and continue the antibiotics. If the patient is symptomatically better and improving, I won't do anything at present. And if the patient deteriorates, I would consider putting a stent. And later on, in near future, in near future, I would follow up the patient and take the stone out in near future.
Okay, so your management is that you want to treat this patient with an antibiotic, and if patient improves, you just want to do the follow-up. You don't
Yes.
want to do any intervention. You will do intervention only when again patient deteriorates. Okay, and if you are thinking that the stone is causing a problem, and in that case, you will first put a digestant, again wait, give the good antibiotics. If any sensitivity is there, otherwise you don't know what antibiotics you are going to give, right? And then you will do RI. Am I right? This is what you are planning? Hamil?
Yes, sir. No.
That
The
creatinine
primary.
is marginally raised, so we have to consider that also, and then we have to put stents.
Okay. So this is Hamil, correct? Hamil says
Yes.
that because the creatinine, even though the patient is hemodynamically stable, but the creatinine is high. So in this case, plus there is a gas in the pelvic ileal system, you want to decompress the system and you want to put a digestant and see the result.
Yes, sir.
And with
So
a
like,
good antibody.
sir.
Correct? This
Yes,
is
sir.
what you are saying?
Yes, sir.
Okay. And then how many days you will keep the digestant?
2 weeks, sir, if patient is improving soon, or 1 month, sir. As per the patient response and urine culture, urine routine will repeat.
Okay.
And
so you will
creatinine
repeat.
levels.
Okay, so you will go for a urine routine culture and creatinine and
And then
WBC count.
ultrasound.
And ultrasound. Ultrasound is not showing anything. Na? Ultrasound has shown 1.5 centimeter stone. Otherwise, nothing else. So what you are going to find in ultrasonography? It was not showing emphysematous pyelonephritis. Okay, so both of you are saying you will give antibiotics, right? And
Yes, sir.
because there is a air in the pelvic ileal system, patient had fever, creatinine is marginally raised, you want to put a digestant, right?
Yes, sir.
And then later on, you will just remove it, or at that time you will do RIRS also?
We can go for RIRS, sir, as it can obstruct.
No, no, what you will do? You want to do or you don't want to do?
I want to do, sir, so that the
Okay.
stone will not obstruct later.
Okay. So now both of you are agreeing that you want to give a good antibiotic, you want to decompress with a digestant, and then at the time of once the patient is stable, okay, and then you will like to do RIRS. That is what you are planning, both of you, correct? Yes or no?
Sir, but I don't
Right.
know. Sir, I have not seen any case of emphysematous pyelonephritis which is going in for RIRS, because even simple RIRS can cause sepsis and all. And this patient is having emphysematous pyelonephritis. If you're doing RRS later, what will happen to the patient? Like, that's very.
Dr. Solai, let me now intervene. Sir,
sir.
can I?
Yes, please now.
Okay. Now, let's make few things very clear. Do not treat any emphysematous pyelonephritis without drainage. Number two, don't call these stones. These are all papillary necrosis. Even on CT scan, they are saying probably stones. CT scan is the best investigation for stone. If they are doubtful about stones, these are low density structures in the pelvic ileal system which are papilla. So for any patient who comes with EPN, the treatment is resuscitation, antibiotics, glycemic control, and deobstruction. Irrespective of where and how the gas is, all patients need to be treated like this. Theoretically, there are reports of treating EPN without stent, but practically you would never treat EPN without a stent.
Yes, sir.
So that's number one.
Yes, sir.
Dr. Solai, when Dr. Gaurang Shah meant about RRS, it was not in the phase when there is active EPN. It is at the time of stent removal once the infection is completely controlled. You see, if you just remove the stent and don't remove the papilla, these papillas would block again. So before removal of stent, it is extremely important to do a flexible ureteroscopy and remove the obstructing papilla. Also remove any partially necrosed papilla which are there in the calyces.
Okay, sir.
The risk of recurrence of EPN dramatically reduces. So, Dr. Hamid, my advice to you will be don't get into this confusion of treating EPN without stenting. In exam, you have to say that the principles are resuscitation, antibiotic, glycemic control, and deobstruction. Now, whether you do deobstruction by a nephrostomy tube or a stent will depend on the overall clinical condition of the patient and the amount of hydronephrosis. In this patient, degestant alone will help. So the plan in this patient will be hospitalization, start antibiotic, get glycemic control, place a stent, see how the patient improves, follow her up with regular ultrasonography and repeated blood test, involve an infection specialist for decision of antibiotics. Once patient is stable after a couple of weeks, when you have documented urine culture to be sterile, then at the time of stent removal, do RRS, remove the papilla.
Yes, sir.
Understood, all of
Yes,
you?
sir.
See,
Yes,
Dr.
sir.
Maheshwari has given a perfect plan. That is what we have done. Understood?
Yes,
The
sir.
thing, see, why I am giving you all the different scenarios, because all these different thoughts will come in your mind and you don't know what to follow. So that is why every time I am asking you 3 or 4 different scenarios. So what you will like to do. And you have to decide what is the right treatment and what is a guideline. So depending on a guideline and our clinical experience, you have to treat this patient.
Yes, sir.
And in the exam, you have to answer accordingly. Okay?
Yes,
Sir,
sir.
we don't have to consider the prognostic factors in these patients, like whenever we are planning for the treatment, like the platelet counts and the mental status, hemodynamic stability, and the
So
creatinine.
you're waiting, na, beta. You are waiting. See what we have decided that you will do a good antibiotic. You are going to hospitalize a patient. You are starting a good antibiotic, and you are decompressing the system. And you are waiting, and regularly you are doing urine analysis. You are doing blood analysis and sonography. And after 3 weeks or maybe 4 weeks, if required, once everything is stable, then you are going to decide for the line of. Understood?
Okay.
So if the platelets are low and all
These
these things are,
These
yeah,
factors are important, but these factors would only decide that your deobstruction procedure will need to happen on priority. If the platelets are low, I would choose stenting instead of nephrostomy, depending on how the situation is. And I would follow these patients on these parameters to see improvement of these parameters.
yeah, fine. Now only if Brijesh, do you have that RIRS video?
No, we had I had taken the photo of the
Yeah, just show them.
yeah. This was a matrix calculus which was removed with the
Removed.
yeah.
So when we went inside, we were really surprised. It was not 8 millimeters. It was a huge, probably a stone, almost 1.8 to 2 centimeters. And it took quite a lot of time for us to break it down and remove all the pieces.
By basketing or what, sir? Like RIRS?
Yeah, RIRS and then basket. Because see what happens if it is a little matrix type of stone, na, and then you cannot make it is like a sand, and it is not going to come out totally. So best thing is you break it and small pieces you remove by basket. Otherwise, you purpose is not served because these are the patients who can again deteriorate, can go into pyelonephritis and urosepsis, and then again lots of procedures. So when you decide to go inside, go with the proper frame of mind that you are going to give a complete treatment. Understood?
Yes, sir. And if we are not able to clear this by RIRS, we have
Then
to
mini
proceed for
PCN.
mini PCN.
Yes, you should go ahead. Because now the patient is stable, everything is under control. This is the best chance for you. You understand?
Sir, is there any role of renogram in this patient as the kidney looks contracted and not of good anatomical delineation, sir?
Yeah, I mean, of course, with this aspect, you can always do. But even if it is going to show, because this is a diabetic nephropathy, creatinine is raised. Okay, whatever the function may be, you are going to save this kid.
So,
There
Hamid,
is no other
as the
reason.
documentation of poor function doing nuclear scan is acceptable, but as sir has said, definitely we are not planning nephrectomy in this patient. We will do conservative treatment or renal conservative as far as possible.
Fine. So I want one of you to say exactly what Dr. Maheshwari has said, how you are going to proceed in such cases of emphysema pyelonephritis where there is some calculus disease in the kidney. Come on,
So,
one
sir,
of you
we
tell
will
me and then we will, yeah.
we will hospitalize the patient, resuscitate the patient, start antibiotics, take good glycemic controls, and then deobstruct the system. And then once the patient is
How you are going to deobstruct the system?
deobstruct, which can be either in the form of DJ stenting or PCN, depends upon the patient condition. Then
Okay.
once the patient is stabilized, then while removing the DJ stent, we can go with RIRS or mini PCNR to remove the these calculus.
So no, you will do RIRS in case if needed to clear the system. If needed, you can do mini PCNF also. But for 8
And
millimeter stone, there is no need. And at the
and
same
sir,
time,
Only addition, Dr. Hamid, I would want you to say here is that at the time of stent removal, I will take a call about the procedure based on the retrograde pyelogram.
yeah.
okay.
Okay.
And sir, post RIRS, like should we keep the DJ stent or we can
That
Yeah.
will
take?
depend on what you find in the RRS. Suppose like in SIRS patient where they removed one bowl full of material from the kidney, you will definitely put a stent again. But if you go in and find one single papilla which you could pull out through the excess sheath, then probably
Yeah.
stenting again is not needed. So
Not
that
needed.
decision will be individualized.
And
Yes.
sir, in this patient, like the similar history, can we take into the consideration differential diagnosis like acute pyelonephritis, EPN, renal abscess, infected cyst, perinephric abscess, or pyonephrosis?
Yeah. See,
Yes.
if the clinical diagnosis, when they ask you, you can always say, okay, sir, this patient has got history suggestive of pain and fever. I'm suspecting infection in the left renal, the thing in the left kidney, and maybe with an obstruction. That is number one, in the form of and either pyelonephritis, and as you said very rightly, sir, because he is a diabetic, I will always keep it in mind of emphysematous pyelonephritis or a fungal infection.
So
Yes,
And sir,
Pankaj bhai.
on your
like you said,
examination, if you on your examination you find that patient is clinically unstable, then keep the diagnosis of EPN and abscess higher.
okay,
Hmm.
But if patient is clinically stable, do not keep these differential diagnosis clinically. Then
Yes.
clinically it will just be obstructive uropathy with infection.
sir, obstructive uropathy, like I said earlier, it can't be the PUJO with the infected hydronephrosis.
PUJO is not a diagnosis I would make in a 60-year-old lady. PU
Okay,
junction obstruction is a diagnosis that you make in younger patients.
okay,
Okay, it is very unlikely in today's time that somebody becomes 60 years and the PU junction obstruction is never diagnosed.
okay, sir. So obstructive uropathy that can be either due
Yes.
to the pap necrosis or
And
stone.
rather do not mention PUJO in a 60-year-old patient. Talk of stone papilla or anything else, even for
Yeah.
that matter, tuberculosis, but not PU junction obstruction.
Okay,
Fine. I think all of you have you are getting a knack of how to answer in the exam. Now, okay. So when you go back also, when you see again in the hospital patient, every patient, you start thinking that this is my patient which will be coming for exam and how you are going to approach. Okay. So every day, one case you decide and think in your mind how you are going to approach, how you are going to answer it, and then discuss with your boss. Fine.
thank you, sir.
Sir, excuse me, sir.
Okay. Yeah.
The picture which is displayed right now, that perineal fats, like are, can you tell what will be the management of this patient? Like, we have to go straight for nephrectomy or what, sir? In this kind of picture.
Yes.
You see,
This is yeah.
never plan direct emergency nephrectomy. The morbidity and mortality of emergency nephrectomy is very high.
So we'll put PCN and then
We
we
will
will.
put probably both
Both.
a subcapsular drain and a degestant. I probably can see left side upper aortic stone also there. So
Correct.
a subcapsular drain and a nephrostomy and a degestant, and then see how this patient progresses.
Okay, sir.
See, I'll tell you, 20 years back now, when the emphysematous pyelonephritis we were getting, usually they used to come with BP 70, 80, and the say was in the Campbell it was written, if you operate, mortality is 90%, if you don't operate, mortality is 100%. But that was very early, like in 80s and 90s. Then with the advent of very good antibiotics, plus this management of de-obstruction, that is by DJ stenting. If it is only involving the pelvic LSL system, DJ stenting will be of a great help. But like case like this, you must put a perinephric drain also.
Yes,
And
sir.
after that, that doesn't mean that is the end of the treatment. With this, patient will improve in next 48 to 72 hours. And that is the time, when the patient improves, don't feel very happy and say, wow, now patient can go home. No, these are the patients, that this is now not going to function and it can give rise to problem again. And most of the time we have seen that if you don't do anything, then another 5 days, 7 days, and patient starts deteriorating. So as soon as patient becomes okay, operate and remove the kidney.
Sir, two more questions, sir. Like when should we remove the stent in these patients if there is no stone or any focus? And second, how do we choose antibiotic in a pan-resistant urine culture, sir?
See, antibiotic, now we have got infectious, I'll tell you very frankly, we have got infectious disease doctor. He's a totally different subject altogether. And depending upon not only, even if it is resistant, that doesn't mean that particular drug cannot work. There is a particular dose. Okay. So I will advise you, if you want, we can keep a small lecture about how to treat the infection in urinary system by an infectious disease doctor. and that may not be only for the exam, but for your practice purpose also. And their fundas and their criteria are totally different. I will advise you in such cases, take their help.
And sir, when should we remove the stent? Like if there is no focus?
No, once the patient is improved, see, minimum is 3 to 4 weeks. After that, whenever you feel, because now, again, this is a foreign body. If you keep it longer, there are chances your ascending infection and other things can also take place. So, as soon as anything, any drain or anything, once you think that it is not needed, remove it. As I told you very rightly, that foci, air foci will remain for a very long period of time.
Yes, sir.
So don't get deceived by that. Don't think that when the air foci will go away, I will remove that.
Okay, sir.
Fine?
Yes, sir. Thank you, sir.
Okay.
Good,
Any
sir. Wonderful
suggestions or
cases.
anyone?
Thank you so much.
Yeah, yes, sir. Yeah. So any suggestions if you have gone and attended that exams, different, even in Calcutta, in Mumbai, and Nadiad, whatever. If you have got any suggestions, please let us know. So we have got another at least 5-6 classes where we can cover up. Okay? Fine. Good night. Yes, Maheshwari ji, thank you very much. You have really guided the students very well. I'm very happy. No, you are very practical and your approach towards the case and answer is very good. And this is what most of the teachers are not teaching.
Thank you, sir.
No, definitely.
Effort आपका है, sir.
So
sir,
they should know how to answer. That's very good.
Thank you, sir. नहीं, cases भी अच्छे हैं, sir, and I think people are making good effort, so it's a job well done.
Correct. Yeah. Thank you. Okay. Good night.
Yes. Good night. Thank you, sir.
Good night.